Hello, I'm Jerry Tan from Western University in Windsor, Ontario in Canada, and it's a pleasure to be here to present to you a Rosacea Update 2021. My conflict declarations are on this slide. The learning objectives are to look at the burden of rosacea, update you on diagnosis and classification, reassess where we are at understanding pathogenesis of this condition, and then importantly, look at the practical aspects of treatment based on features of this condition. The burden of rosacea was evaluated fairly thoroughly in a series entitled Rosacea Beyond the Visible. And the question we asked was, how does rosacea impact people? And we know it impacts people psychologically, emotionally, and it has broader impacts for our society and healthcare systems. 1/3 of those with rosacea reported a high impact on their quality of life, and over 82% felt that their disease was not properly controlled. Of interest is the fact that many of the features of rosacea have a misdirected impact estimation by physicians. For example, compared to what is affecting patients, what is overestimated by physicians are bumps and pimples, visible red small blood vessels, that's telangiectasies, persistent redness, and flushing. Interestingly, what was underestimated by physicians was the fact that some of the features that were not evaluable visibly impacted the patients quite a bit. For example, pain of the skin, itching, stinging, and burning. So it's important that we ask our patients about their symptoms. We also looked at psoriasis of the face versus rosacea because there's such a large wealth of information about quality of life impact of psoriasis and very little information on rosacea. So we wanted to use psoriasis, in this case, psoriasis of the face, as a comparator for rosacea. Patients with psoriasis of the face, as you know, often also have psoriasis of the scalp and also have extensive psoriasis on other parts of their body. But interestingly, both had a similar burden on mental health, despite this difference in overall surface area involvement. 1 in 2 patients in both conditions reported moderate to severe depression. And 30 to 40% of patients with both conditions reported moderate to severe anxiety. And overall, 70% were worried that other people might notice they have a facial skin disease. Why is that problematic? Because we make judgments based on appearance. And that judgment can lead to stigmatization, that is devaluing the value of somebody based on what they look like. So in both rosacea as well as in psoriasis of the face, there was an increase in concerns about confusing and staring behavior and experiences thereof. There was also an absence of friendly behavior and even outright hostile behavior because these patients are stigmatized. Rosacea patients are also more emotionally impacted. You can see that there's a greater prevalence of concern regarding flare-ups. There's a lower self-esteem compared to psoriasis patients which have facial involvement, and there's lower self-confidence. And importantly, rosacea patients were more likely to self-blame themselves for flare-ups. Why is that? Because of the concern regarding the guilt that they are not managing their triggers appropriately. Let's take a look now at what I think has been a problem in rosacea diagnosis and classification over the past 20 years. And what we're aiming towards is greater accuracy, simplicity, and practicality in diagnosis and classification of this condition. We had revised the diagnosis and classification of rosacea in 2016. This was the recommendations for the Global Rosacea Consensus Panel. And a year later, it was endorsed by the National Rosacea Society. What did we do? Well, we wanted to make it very clearly apparent that diagnosis required the presence of high sensitivity and specificity features, and that is persistent centrofacial erythema or phyma. And each of these could be individually diagnostic of rosacea in the absence of other conditions that cause them. Major criteria were where any two were required for diagnosis, that is transient facial erythema, inflammatory papules and pustules, telangiectasies as long as they are not the ones that are perinasal or at the alar regions, and ocular features. The minor features were not necessary for diagnosis, but they were important in trying to understand whether patients were so affected, burning sensation, stinging, edema, and dryness, because these are some of the aspects of rosacea that might be of concern to the patient in terms of symptomatic relief. The National Rosacea Society in 2002 presented this subtype classification that provided 4 subtypes and a variant, that is the granulomatous variant. And if you notice, 2 of these subtypes, erythematotelangiectatic and papulopustular, contain multiple features. And therein lies the problem. The multiple features can extend across different subtypes. For example, facial erythema can be a component of subtype 1, subtype 2, subtype 3, and subtype 4. And these subtypes are erythematotelangiectatic, papulopustular, phymatous, and ocular. As can telangiectasia, they can extend across all of them. Inflammatory papules can be a part of subtype 1, subtype 2, and subtype 3. And phymatous changes can be across all of these subtypes, as can ocular manifestations. So it's very problematic because it doesn't give you any notion of specificity. So this is what I call confusion by overlap. We wanted to replace the idea of subtypes with features. It's more accurate, it's more simple, and it's practical. And they're based on the diagnostic features, the major features, and the minor features we've just talked about. So we would like to remove the word subtyping from rosacea. Let's look at pathogenesis. Rosacea pathogenesis, as we know, has multiple external triggers or aggravating factors, from demodex to stress, exercise, food, heat, and ultraviolet light. How can so many diverse trigger factors impact to lead to specific outcomes? Well, it seems to activate through stimulation of the innate immune system, and that leads to this inflammatory cascade with inflammasome activation, as well as the activation and stimulation of cathelicidins, along with neuroinflammation. And this combination of inflammatory outcomes leads to the features of inflammation, pain, erythema, vasodilation, and tissue remodeling, which might lead to phyma. The management of rosacea has been evaluated in a number of different publications, one of the most useful of which is this one that is evidence-based, and it's on the basis of looking at the phenotype approach. It's an updated systematic review, including assessment of study quality using grade assessments. And this table is derived from that, along with one of the more recent papers from the Roscoe group. And it indicates that the quality of these studies, the evidence is moderate to high in green, low to moderate in blue, and very low to low in black. So for example, with erythema, we see that there is high quality evidence for alpha adrenergic agents and very low to low evidence for beta blockers. And across for mild, moderate, and severe inflammatory papules and pustules, there's high quality evidence for azelaic acid and metronidazole in the topical group for mild, as well as for moderate. But for moderate, it also includes topical ivermectin and more recently, the approval of minocycline foam. And these products can also be used for treatment of severe inflammatory papules and pustules because the studies were designed that way. We also see high levels, which are moderate to high level evidence for doxycycline and minocycline in treatment of mild, moderate, and severe rosacea. And in patients who have severe inflammatory papules of rosacea, isotretinoin can also be considered high quality. And the utility of a table like this allows you to kind of focus on what has been shown to be highly effective and what can be tried but may be of lesser quality in terms of background evidence. So for example, in a patient such as this, and you see he presents with both centrofacial erythema as well as papules and pustules, you may want to start off with ensuring all patients are counseled on gentle cleansers, moisturizers, and sun protection. And of course, because he has centrofacial erythema, you may want to review the use of alpha adrenergic modulators such as oxymetazoline or brimonidine, and or consider the use of intense pulse light or a vascular laser. Because he also has papules and pustules, anti-inflammatory topicals such as the ones we talked about, metronidazole, ivermectin, and azelaic acid, those may be ones to consider topically. And of course, the oral treatments may also be worth considering, particularly if they have more severe presentations or if there are a lot of symptoms and signs. So some of the special considerations in terms of when to use the treatments, including IPL or vascular laser, considered prior to topical alpha adrenergic agents for persistent erythema, that can be a consideration. The other one can be the use of topicals before oral agents for mild papules and pustules, and early use of oral antibiotics in combination with topicals if the condition is more extensive. So in summary, this was a short recap of what has happened in rosacea research over the past few years. The first is the human aspect of rosacea. Why is it so burdensome? Because patients present with red faces, and redness in society is a sign of anger. It can be a sign of embarrassment, or it can be a sign of alcohol intake, all which are miscommunications when a patient has rosacea, because that's not what the message should be. But nevertheless, that's how patients may be perceived in society, so they can be stigmatized. They have symptoms that we sometimes don't ask adequately about, so it's important to understand what symptoms of the skin bother the patients. Number two, diagnosis and classification. Over the past 2 decades, we have been mired in some confusion regarding diagnosis and subtyping. And we are hoping that the move towards phenotypes and features will be simpler, clearer, and more scientifically based. Pathogenesis in rosacea outcomes is really a continuum of inflammation from inflammasome activation, innate immune activation, and then the neuroinflammatory cascades as well. And lastly, there are treatments based on features that are evidence-based recommendations, and I recommend that you take a look at that if you are so interested. It is open access for you. So thank you very much. I hope that was of help.